Thank you. So, good evening, all our esteemed members of Maharashtra Ophthalmological Society, those members who are also joining us today from at large All India Ophthalmic Society, especially all our young stars, all our young residents who are specially joining this PG program by MOS, which is a specialized initiative in which Team MOS is actually bringing to you one specialty each month to take you through the exam going cases, also a lot of practical discussions which will help you not only in your academics, your education, but also in your future practice at large. So we are very happy to have today as our panelists nationally and internationally renowned speakers and our faculty, Dr. M.S. Ravindra sir. Sir is the chairman of the Karthik Netralaya from Bengaluru. He is a alumni of the prestigious Shankara Netralaya, one of the first fellows of Chief Dr. S.S. Badrinath. Sir is a very prolific cataract surgeon, one of the first surgeons to implant advanced premium lenses in Karnataka and beyond. And I must say that Sir is one of the best teachers that we have come across when it comes to the cataract practices as well as the OT sterility protocols, etc. Last year also, when MOS had conducted a OT technicians course, Sir was a great resource for the same. So thank you, Dr. M.S. Ravindra sir, for joining us today. The next one is Dr. Jeevan Ladi sir. We are very happy to have Sir, who is a past president of MOS, of POS, and Sir is a very prolific cataract and refractive surgeon, has been at forefront of research and innovations, and has recently won his best research paper at AIOSC, which happened just recently in Kolkata. So thank you, Dr. Ladi sir, for joining us also. Now, we would like to also thank Dr. Pankaj Shah, who has been a past treasurer of MOS, who has joined us as a moderator. Today, are going to be having two case presentations, and it is going to be mentored by Dr. Avantika Savade from Nagpur IGMC. Team MOS is very thankful to the year-long coordinator of this PG program, our young star, Dr. Sumit Lahane, who has worked tirelessly to put down all these series of PG program month after month. So thank you so much, Sumit, for all your hard work and meticulous planning. Now I would like to invite our honorable president, Dr. Santosh Agarwal, sir, who has led from the front the team MOS in this year and has also made it possible for MOS to win the Best State Society of the Country Award second time in a row. So over to you, sir, for your welcome address.
Thank you, Vardhaman. All the dignitaries in the webinar, I welcome you all and good evening to one and all. Especially, I thank Dr. Ravindra sir and Dr. Jivan Ladi for giving their valuable time today for this webinar. I also welcome Dr. Avantika madam, our PG postgraduates who are going to present their cases, especially on the complicated cases of cataract. And definitely the discussion will enlighten all of us. And this PG program is aimed at giving the practical knowledge and the how to face the viva in practical exams. So that will definitely help our PGs. And I thank especially Dr. Vardhaman, Dr. Sumit, who are instrumental in crafting this program, PG program. And it is welcomed by all our PGs and members as well. I also thank our moderator, Dr. Pankaj, and also my MOS team for giving their valuable time for these activities. Thank you very much for giving me this opportunity. Over to Vardhaman, please.
Thank you very much, sir. I think, sir, we are waiting
and
for
lastly,
your quote.
one quote from my side. Always I put one quote for the PGs. Just so for PGs, if you believe in yourself, anything is possible. So believe in yourself. That is my message today. Thank you very much.
Thank you very much, sir. All these quotes inspire all the PGs and all of us also. So now I would like to hand over the proceeds of this webinar to our dynamic PG coordinator of the program, Dr. Sumit Lahane. And again, thank you, Sumit, for all your hard work. Over to you, Sumit.
Thank you so much, sir. So thank you, Team MOS, Vardhaman sir, Santosh sir, Atul sir, Aditi ma'am, for giving us this platform and giving us the opportunity to connect with all the PGs. And all the PGs are very lucky to have such a MOS team, which provides them such an opportunity to present in front of the legendary mentors. So today we have a moderator, Dr. Pankaj Shah sir. Pankaj Shah sir being office bearer of MOS previously, and we have done a lot of programs together. Thank you, Pankaj sir, for being here and taking out time from your busy schedule. I would like to thank Dr. Avantika ma'am for mentoring two PGs and on such a short notice post AIOS and being here. And we have stars for today, Dr. Divisha Jain and Dr. Akhilesh Rathod, who are the third year exam going PG students from IGMC Nagpur. I would hand over now to Pankaj Shah sir for introducing our mentors, and then we will start with Dr. Akhilesh with his case presentation. Over to you, Pankaj sir.
Good evening, all of you. Thanks, Sumit. Thanks for giving such a wonderful opportunity to be here with all the panelists and esteemed speakers, panelists, and all of you. We have Dr. M.S. Ravindra sir from Bangalore, who is cataract and specialty oils with cornea and vitreoretinal specialty. He has done his MD ophthalmology for AIMS and Topper in 1978. He has a Kartik Netralaya as a medical director, and he was former Karnataka Ophthalmology Society president and Bangalore Ophthalmology Society president. He was AIS Presidential Green Committee chairman member also. The second panelist we have is our very famous Dr. Jeevan Ladi sir, who is past president of MOS, a past president of Pune Ophthalmological Society. He has a gold medal in his MS examination, ex-president Pune Ophthalmological Society, and recently received the best paper at AIS also. So, and we have Dr. Avantika Chowde madam from IGMC. So now we'll
Dr. Akhilesh, you can share the screen. I think Akhilesh is not here. Dr. Devisha, are you ready? Can you share your screen, please?
Akhilesh was there.
I think some internet issue on his side. I will contact.
Yes.
Devisha, can you please share the screen?
Yes, sir. Actually, Akhilesh is joining only.
Okay. That's okay. You can please start. We can't waste time for that.
Okay. Good evening, everyone. First of all, I am very thankful to all the MOS committee members for giving me such a golden opportunity for presenting the case on online platform. And I'm very thankful to all my teachers and mentors who mentored me during this phase. So today I'm presenting a case on uveitic cataract, a 30-year complaint. Firstly, the complaint, a 30-year-old patient, resident of Nagpur, teacher by profession, came with the complaints of decreased vision and pain in both eye, left more than right eye, since 4 to 5 months. History of presenting illness. According to patient, he was all right. He was all right 4 to 5 months back when he developed diminution of vision, which was gradual in onset, progressive in course in his both eyes, left more than right. It was associated with pain, redness, and photophobia. Additionally, he mentioned there was intermittent episodes of redness and pain in his left eye for the past 3 to 4 years. These symptoms are progressively worsened over the time. And there is no history of trauma to eye, recent illness or medications or spectacle use, contact lens usage. Patient also denies any history of systemic illness like diabetes, hypertension, or any other autoimmune illness. Past history. Patient is giving a history of uveitis dating 3 to 4 years back, for which he received intermittent treatments, but he never follow up with the doctor. He's also giving a positive history of lower back pain, which has been managed conservatively by himself only with over-the-counter drugs. There was no history of ocular surgery or significant trauma or joint pain, oral ulcers, or genital ulcers. Personal history. Patient is a non-smoker, denies any alcohol or substance use, with no history of appetite loss or a weight loss. He works as a teacher, and there is no significant environmental exposure. There is no relevant family history of any autoimmune disorders. Systemic examination. On systemic examination, patient appears healthy. All his vitals are within normal limit, and rest of the systemic examination is within normal limit. Now coming to the ocular examination, his head posture, ocular position, and extraocular movements all are within normal limits. Visual acuity, uncorrected visual acuity in right eye on Snellen's chart is 636, which is improving to 624, and with the -1 dioptric spherical lens. In left eye, it is finger counting at 2 meter, which is not improving with correction. His cornea is having yellowish pigmented, yellowish deposits on the endothelium, suggestive of old capes in both eye, and there are few fine capes in the inferior half of the corneal endothelium in the left eye. Anterior chamber in right eye, it is normal and it is quiet. In left eye, it's quiet, but it's having irregular depth. Iris, the color pattern is normal, but there are few posterior synechiae at 10 o'clock and 4 o'clock, as shown in this photo. Two synechiae are seen. Pupil in right eye, it is normally reacting to light, and in left eye, it is sluggishly reacting. And on dilatation, pupil was not dilating more than 4 mm in left eye. Lens in right eye, only early posterior subcapsular cataract changes are seen. In left eye, nuclear sclerosis grade 2 with posterior subcapsular cataract is here. IOP in both eyes within normal limit. Coming to the fundus examination, in both the eye, fundus is normal. There's no sign of inflammation, and both the fundus are within normal limits. My diagnosis of this case is both eye complicated cataract post uveitis. Thank you.
Yeah, it's nice.
Thank you.
Madam, can you start the discussion? Any questions to be asked to Divisha, madam?
Yes, sir. Very well presented, Dr. Divisha. So, what is a complicated cataract?
It is a type of a cataract which is caused due to disturbance in the nutrition of the nucleus, disturbance of the nutrition of the lens, either due to inflammatory or the degenerative changes for in other part of the eye. For example, iridocyclitis, choroidal tumors, retinitis pigmentosa.
So, what are the surgical challenges that you will face while operating a case of complicated cataract?
First of all, because of like it's as in this case, there are posterior synechiae. So due to posterior synechiae, the pupil, and also due to the not in my case, but there are chances of iris atrophy. Pupil generally does not dilate well. As in my case, pupil was dilating to up to 4 mm only. So due to small size of pupil, there will be problem in doing capsulorhexis. There it will hamper the vision, and it will obstruct our view while doing irrigation and aspiration. And secondly, because of irregular depth, we will have shallow anterior chamber. Sometimes we have shallow anterior chamber, and that's why while doing surgery, it hampers the intraocular manipulation of the instrumentation. Then sometimes there are fibrotic membrane or pupillary membranes are there, because of which it causes difficult capsulorhexis. And then further there are like
there can be new vessels in the angle.
Yes, ma'am. There can be new vessel in angle in few cases, like Fuchs heterochromic Fuchs heterochromic iridocyclitis. In these cases, while performing surgery, there can be hyphema or blood in the anterior chamber, which can further cause post-operatively there can be a inflammatory signs, and along with during surgery, it will hamper the visualization, and difficulty in surgery will be there.
Also, zonular weakness can also be seen in these patients.
Yes, ma'am. Zonular weakness is also there sometimes.
What are the preoperative examinations and investigations that you will conduct?
First of all, there should be a detailed slit lamp evaluation should be done in these patients to rule out any sign of active inflammation. As before operating, there should be no sign of active inflammation. And similarly, there should be a detailed fundus examination to rule out any active sign of inflammation. Along with that, we should also rule out any macular edema or any macular involvement because of epiretinal membrane or CNVM or any macular scar. Or we should also look for disc changes because of long steroid intake. There can be glaucomatous disc changes. So because of that, we should look after these changes, and because of these changes, we can explain the guarded visual prognosis to the patient also. So it will be helpful in post-operative vision correlation firstly. And furthermore, we should also look for any sign of inflammation in posterior segment. Then coming to the investigations, firstly we should confirm these findings. So we can do B scan for any sign of vitritis or any choroidal detachment or retinal detachment or exudative retinal detachment to rule out these findings. And this B scan is also helpful in those cases in those cases in which fundus is not visualized because of dense cataract also. So we can do B scan. Then we can do OCT for because in uveitis cases there are chances of macular edema. So OCT, firstly, it can document also, and it can help us to see whether the macular edema is progressing or decreasing. So it will be helpful in that also. So we can do OCT also, and for anterior chamber we can do ultrasound biomicroscopy. It can also show the sign of inflammation if there are inflammatory sign, or we can see any cyclitic membrane or any changes in the ciliary body or ciliary body tumors are there. So we can see those changes in ultrasound biomicroscopy. And few people also do potential acuity meter also to know whether we have what is the visual prognosis after the cataract surgery in this patient. Because of dense cataract, it can also be used. And as in my patient, there are synechiae, so we should also do IOP measurement. Because of synechiae, or when there is occlusio pupillae, IOP can be raised. So it should be first-handed confirmed that IOP is not raised before doing the surgery.
Yes. How will you manage a small pupil in complicated cataract?
Small pupil can be managed pharmacologically, but sometimes. But in these cases, because of synechiae, it is not of very usefulness. We can do synechiolisis in these patients. Synechiolisis using iris repositor or visco synechiolisis also done using the visco. Or we can do the mechanical stretchers or mechanical stretching of the pupil. It can be done with the Y pushers or Kugan hooks. Or but the main problem is with that, if we do prolonged stretching, it can dilate the pupil for longer duration. Sometimes it doesn't reverts back to it damages the muscles of the iris. Then we can also do sphincterectomy, but the problem is same with sphincterectomy also, but it causes the permanent dilatation of the pupil. So that's difficult in sphincterectomy. Or we can use iris hooks or pupil expanders like Malyoun ring, B-hex ring, and I expander. Like there are few rings. Malyoun 2.0 is there, and we can use that.
Which type of IOLs do you prefer in such cases?
Mostly polymethylene metaacrylate lenses are used. rigid polymethylene methacrylate, or in cases of foldable, then the tips of the haptics are coated with PMMA. We can use those lenses, and we should we can also use heparin coated lenses.
Hello.
Those heparin coated lenses are also used in these cases, and mainly, and the main thing in these cases is we should put the lens in the PC bag only. Avoid putting the lens in the sulcus because it will constantly irritate the iris, and there is capsular contraction in these patients post-operatively. So we should put the lens in the bag and try to do a large capsular excision in these patients to avoid anterior capsular phimosis.
Very nicely told. Good answers by Divisha. Now, good. I request panelists to highlight us on pre-operative use of topical and oral steroids. Ravindra sir, please can you highlight us on the usage of systemic and topical steroids pre-operatively?
Good evening to everybody. It's a very interesting webinar. I should congratulate all the people who conceptualized this program. I'm enjoying the presentation of a postgraduate student. She has literally covered everything that needs to be told by a student in an exam. Beautifully, very nice. So about I'll just add one or two. One of the things that happens to the cornea may look very clear, but the endothelial count may take a dive. It's very important to assess the endothelial count in these patients so that you can be very careful to preserve if there is an endothelial loss. We all say the inflammation has to be under good control. So when do you say it's under good control? Can you tell, Divisha? What are the slit lamp findings to say that for 3 months there is no active inflammation, because your steroid will depend upon what stage you operated?
Yes, sir. Sir, there should be no cell in the anterior chamber.
No
Flare
cell
can be.
Okay. Flare. Go ahead.
Flare can be there, but cell should not be there in the anterior chamber.
It's what about vitreous?
Same
In
with
your
the
case, vitreous was clear, you mentioned, but you may not have observed the fineness of vitreous because of the cataract. So vitreous cells will remain for a long time. So presence of vitreous cells is not a contraindication to do a cataract surgery because it's very difficult for them to go away. But the aqueous, as I said, the cells counts must be less than 5 for at least 3 months' time before you take the patient for surgery. So if you look at the literature, there is controversial all these days. Many for years, decades together, we used to start the patient on systemic steroids as well as topical steroids week, 2 weeks, 3 weeks before. But the current the studies which compare the cases and the final results of the surgery done on quiet eyes with the preoperative steroid and without preoperative steroid, the difference was not much. So based upon the case that you are looking at, you can decide whether you want to take a small risk of endophthalmitis or fungal infections by starting the steroids, or you can start steroids just a day or two before. But you can start NSAIDs weeks and months together before that. Not only the inflammation will be down, NSAIDs will act definitely on uveitis, makes it quiescent. It dilates the pupil well during surgery, and post-operative recovery also will be smoother if you have started NSAIDs before surgery. So systemic steroids, I see that there is no role unless you are forced to operate on an active stage. But then topical steroids, depending upon the case, how it is, you can decide whether you want to start it. It's better to start 1 or 2 days before rather than weeks or months before the treatment, the surgery.
Nice. Thank you, sir. Ladi sir, will you like to add any points?
Yeah, it's a very good presentation. I love the discussion, and the person who was presenting thoroughly presented everything. But now what we are talking about is left eye, which has a posterior synechia. Am I right, ma'am? Okay. So one thing which I would like to add is that start local steroids, preferably prednisolone acetate, at least 15 days before the surgery. So some level of steroids, anti-inflammatory is already there into the anterior chamber, and then we can pose the patient for the surgeries. The aim of this surgery has to remove the synechia, dilate the pupil, and never ever forget to do a peripheral buttonhole iridotomy at the end of the surgery. Because this is a surgical protocol which we are talking about, but we don't know what is going to be the future of this patient as far as the information is concerned. So people should not get blocked. So peripheral iridotomy is the key issue in this patient. So if you don't mind, we already talked about the BHEX. We have talked about the iris retractors which are used. If you don't mind, I can show you two simple techniques which can be used even by the novice surgeon, and we can go ahead with that. Is that okay with you?
Yes, sir.
Okay. Can I have the share screen?
Yes, sir. You can share. No? Yeah.
Okay. Thank you. You can see this, how much it is going to be helpful, I really don't know. But this should be tried first because this is a medical line of treatment in which we have a phenylephrine, we have propicacil, and we have a lignocaine as a thing, where you can try this. If this is not working, fair enough. This is just a 30 seconds video. I'm starting it. Okay, now you saw that the people which was not dilating initially has come back to more than, you can say, a 6 millimeter, or you can say 7 millimeter. Okay, so let's come to this one now. I don't think anybody has shown this before on this platform. This is actually a very simple technique which anyone can use. I can talk directly. There's no issue. This is the first post-op day. We can see here. Yeah, the idea here is to show that you don't have to use a very complicated method. A simple. Can you hear me now, Dr. Pankaj?
Yes, sir, we can hear you.
Yeah. So the idea, I didn't know that the voice over was not recorded, but this is a simple technique by which you use a pliable a silicon material which dilates your pupil to a comfortable level by which you can complete the procedure. Only thing which I suggest that when you take a side port, usually we take side port at the parallel to the iris. Here you have to take little bit down so that you can put your forceps inside to take out the iris and do iridectomy. So iridectomy is the most important thing. I would like to put this patient onto local steroids for a period of at least 3 months, and then onto a milder steroids for a period of another 3 to 6 months, and then decide whether shall we continue any mild steroids or not. This is what is my call on this case. Thank you.
Thank you, sir. Nice video and nice discussion. I would like to ask Dr. Ravindra sir, what is the role of antivirals if it's a herpetic keratouveitis and with cataract? Can you highlight us?
Yeah, in herpetic, if you show that the uveitis is herpetic and then the cataract is due to this thing, cataract is one of the surgical stimulus or stimulus for the reactivation of herpetic keratouveitis. So it's always nice to start on oral antivirals, either acyclovir or valsiclovir, 400 or 500 milligrams, 1 to 4 weeks, depending upon how many times the patient had recurrences, when was the last recurrence, depending upon that. Well, 1 week before at least, it's nice to start it before that. Because after cataract surgery, there could be a reactivation of the viral uveitis.
Post-operative, sir, we should continue?
Continue for a couple of weeks or even a couple of months' time till the active phase of inflammation is gone. So, for example, a month is all right.
Role of posterior subcutaneous injections in these cases?
Sorry, before we go ahead, sorry, I'm sorry to interrupt.
Yes, sir.
If it's an active viral infection, we have to give at least 400 milligram 3 times a day for a period of 15 days. When the active phase is lost, then we can have at least 100 to 100 milligram to be given for a period of minimum 1 year. The reason being that this is the dormant virus which remains into the ciliary ganglion and come down anytime into the eye and cause inflammation. Thank you.
Yeah, nice. What is the role of subcutaneous injections, sir, presently? Do you recommend or you give subcutaneous?
So they basically are looking at the anterior segment in these patients, and subtenon has to migrate to the root sclera into the vitreous cavity. Unless it's a pan-uveitis, posterior subtenons will not be of any use. The adequate dose of steroids will reach from the topical medications, or if at all is necessary, a subconjugal injection. Topical is probably good in majority of the cases. And posterior subtenons, I don't think has got any specific role in the anterior uveitis and the cataract caused by.
It can have a less chance of cystoid macular edema, any post-operative.
See, cystoid macular edema, it's not that it comes in every case. If you have taken care that the inflammation is curtailed, if you have taken care that one of the things that you should be very adamant, very strict about is removal of the entire cortex. Cortex, as you know, is an antigen, and we should be meticulously remove every bit of cortex, clean the capsular bag and put the lens inside the capsular bag, and take all the precautions we have, like especially cycloplegic drops. So that's a must in these patients, post-operatively too. And the need for the CME is definitely more than a good non-uveitic cataract. But then if it comes at that time, you can handle it. That's what is my logic rather than giving it and landing in problems.
So any role of intracameral dexamethasone?
Dexamethasone and triamcinolone, I would rather use triamcinolone. I look for a reason why we should use triamcinolone and then use it very diluted, 1:5 diluted triamcinolone, and wash it out. A little bit of the molecule that is stuck on the iris is probably good enough. I would prefer that rather than the dexamethasone. Dexamethasone given intracamerally and dexamethasone given topically, the concentration that's reached in the aqueous is probably similar. So you don't have to take an additional risk of putting steroid inside the eye.
Is there any role, Sir Ladi sir, any role of less phaco time or less illumination with the outcome, post-operative outcome of these cases?
I'll first come to the triamcinolone given intracamerally. Once you inject it in which are concentrated, we don't have a control over intraocular pressure in these patients. So I would prefer to give local steroids more intensively if required, if there is inflammation, than to give something which is intraocularly unless the case is too severe, because once the IOP is increased by this, and this most probably blockage causes the blockage to the you can say the glucosamine garments of trabecular meshwork, we cannot revert it back. So now then we have to go back to the glaucoma management more than inflammation management. So I would prefer to go more on to local steroids than intraocular, especially as far as this case is concerned. That's first part. Sorry. The second part you mentioned is, what was it, sir? Dr. Pankaj?
Low phaco time or low illumination, what is the correlation? Will it?
See, most of these people have a pupil which is not very well dilated. So pupils are not very dilated. So I would like to go with a very low parameter. The reason being that the iris is so friable that even if you are 1.25 millimeter near the pupillary margin with your phaco probe or phaco tip, it's going to suck on the iris. So I would prefer to do all the manipulations in central 3 millimeter while doing a phaco. All low parameters, unless cataract is too hard. If it is too hard in 3 millimeter, I would use more energy. As soon as the central part of the cataract is removed, I'll go back to the as low possible as possible to low energy in phaco. So if it's a hard cataract, suppose I'm using a 60 in central 3 millimeter area. For rest of the cataract, I will resort to something like a 20 to 30 power, not more than that. I would like to keep the bottle height 20% less than usual cases. The reason being that there is too much of a flutter of iris in these cases, and they cause a lot of inflammation and antechamber coming, getting shallowed because of the fluid flowing behind that because of the small pupil. These are the three things which I would recommend as far as the phaco is concerned. Otherwise, there is no issue.
In such old iritis cases, if we use iris hooks or rings, will it be adding more to the trauma and inflammation?
Yes, we do. Like the iris retractors which are used, or you can say a stretching is used by two instruments, is good for other cases. But the case which has been mentioned by the man here is the iris is already inflamed and friable. And if you try to stretch them, they will become more friable and damage the tissue. If there is a damage to the iris sphincters, that is, we are talking 1 to 2 millimeter from the margin of the iris, the pupil will not have a permanent dilatation. So when do you get a permanent dilatation of pupil? When you damage the mid-periphery of your iris, that is iris musculature, which are going crisscross. If you damage them, then you will have a permanently dilated pupil. So I would prefer to have a retractors which are not putting too much back onto the iris, just good enough for you to do the procedure and put it back. So that will keep your pupil in good position. Thank you.
Thank you very much, sir. Any points you would like to add, sir? Ravindra sir?
Yeah, see, now I've completely switched over to not using any pupil dilators. I'll tell you exactly what I do. Make a entry into the antechamber and fill it so that the iris goes back to the. I don't push it too much, but push it so that it goes to one level. And then I take micro vitreous scissors, like tiny scissors which can go through the 2.8 channel and do very tiny cuts. Dr. Ladi clearly mentioned if you make half to 1 millimeter cut, people reacts and this goes back to original size. If there is no permanent damage to the sphincter because the concentric fibers are not cut. But then if you take very tiny cuts, just enough, I would say rather 0.5 millimeter multiple cuts all around, And then you can see beautifully the pupil dilates easily to about 5 millimeter in every single case. Even today, I had operated 2 cases of similar cases. And after that, put this viscoelastic and it beautifully dilates for you to do a good rhexis and the cataract surgery. So I've almost totally avoided any kind of pupil dilators since I've done this. Even that stretching is not necessary. But in some cases where it doesn't dilate beyond 3 millimeter, you need to diagonally stretch it. But even don't go till the nimbus, mid periphery is good enough. And that way you can have a real round people, reacting people, beautiful people post-operatively. At least you will see those tiny cuts, but that doesn't disfigure the shape or size of the pupil. So I've completely switched over to this kind of pupillary dilatation. But everybody should know there are 4 or 5 or 6 kinds of various kinds of pupillary dilator, pupillary dilating devices, and the postgraduates should be very familiar with how to use it.
Thank you very much, sir. Now, I think we have had enough of discussion on this case. Now we should go to the case of Akhilesh. Let's see what he is presenting. Akhilesh, are you ready? Akhilesh?
Yes, sir. Hello.
Please share your screen and start with the case.
Yes. Uh, 56-year-old male resident of Nagpur, farmer by occupation, came to OPD with chief complaint of diminution of vision in his left eye since 1 year. The patient was apparently all right. 1 year back, he noticed decrease in vision in his left eye, which was insidious in onset, gradually progressive, and painless in nature. There is no history of any systemic illness, no history of any recurrent redness and intolerance to bright light. There is no history of thick spectacle use. There is no history of any drug use. Past history, there is history of trauma to his left eye by his grandchild while playing 1 year back. There is history of right eye surgery, which is possibly a cataract surgery 2 years back. Personal history, normal bowel bladder habits. There is no history of any addictions. Family history is not significant. General examination, the patient is conscious, coherent, and is within normal limit. The vitals are stable. Systemic examination is also within normal limit. Ophthalmic examination. Head posture of the patient is normal. Ocular position is normal. Extraocular movements are normal and full range. The visual acuity in his right eye is 6/18, which improves to 6/9 with pinhole. In left eye, it is PR accurate. Near vision of right eye is N24. Left eye, it is not accessible due to dense cataract. Intraocular pressure of right eye is 14 millimeters of mercury. Left eye is also 14 millimeters of mercury. Both orbit margins are palpable, continuous, and non-tender. Nasolacrimal passage of both eyes are non-regurgitant on pressure. Anterior segment of right eye, there is pseudophakia with the rest anterior segment within normal limit. In left eye, lid conjunctiva are normal. Cornea is clear, sclera is normal. Anterior chamber, there is irregular depth in the anterior chamber with no evidence of vitreous. Iris, there is iridodonosis with normal color and pattern. Pupil is normal in size reacting to light. Lens, there is chromatic mature senile cataract with phacodonosis. On dilated evaluation, both pupils are 8 mm dilated. In right eye, PCIOL is present. In left eye, chromatic mature senile cataract with phacodonosis and zonular dehiscence from 6 to 11 o'clock is present. Here is the picture of the case which I'm showing. On posterior segment examination on indirect ophthalmoscopy, in right eye, red glow is present and the fundus examination is within normal limits. In left eye, there is no glow because of the dense cataract. My provisional diagnosis based on this examination, it is right eye pseudophakia, left eye is temporally subluxated traumatic mature senile cataract. Thank you.
You can stop.
Madam?
Yes, sir.
Yes,
sir. Nice presentation, Akhilesh. Nice presentation. I would like to ask you one question. Which is the one thing that you would like to look for in a case of traumatic subluxated cataract in slit lamp examination?
Ma'am, in slit lamp examination, I would like to look for is there any evidence of any vitreous in the anterior chamber in case of subluxation or any cells are present?
Yes. So if there is presence of vitreous in anterior chamber, we must manage it at the beginning. After doing the capsulorhexis, we should fix the capsule with the capsular group and manage the vitreous with 2-port assisted with triamcinolone. Where will you prefer to give incision in your case?
Ma'am, in my case, as the subluxation is like the zonular density, it is from 7 to 11 o'clock. The incision should be given on the opposite side of this. Like it should be given temporally in this case. Opposite, like where the zonules are strong, there is like a strong support to the lens capsule.
The main incision must not be where there is weak zonular support. Also,
Yes,
the paracentesis incision, it should be more corneal to avoid any damage to the capsular margin. What will you do? How will you manage a case of 3 clock hour zonular dehiscence in this case, in such a case?
ma'am, in 3 clock or distance, ma'am, the like the after the capsulorhexis, it should be initiated with cystitome. It should be completed, and there should be like a gentle hydrodissection should be done, and the IOL placement, like capsule tension ring can be used, or if it is not available, the IOL it should be placed in such a way that the haptic should be the haptic should be in the place where there is like less zonular support, where the zonules are not present.
Yes, and
Or
placement, capsule tension ring placement.
Sorry, ma'am.
CTR, capsular tension ring
Placement, yes, ma'am.
Yes.
And the lens can also be like the lens can also be placed in sulcus with the IOL in bag, optic in bag, and haptic in sulcus, like in this manner. Sorry, optic in sulcus and haptic in bag.
Haptic
Yes.
in sulcus and optic in bag.
Optic in bag.
Or the haptic in in area of zonular dehiscence. You should keep the haptic in area of zonular dehiscence. In a case of cataract, which stains you should use?
Ma'am, like the trypan blue, it is used for staining the anterior lens capsule. Then like if you are suspecting any vitreous, then triamcinolone acetonide can be used to stain the vitreous for managing the vitreous coming out. Then for staining anterior capsule, diluted lissamine green can also be used. Like these stains can be used.
Okay. I would like to ask the esteemed panelists, what are the use of capsular hooks in such cases?
Can I talk?
Yeah, Adi sir, please.
I think we should go from a basic. When there is a trauma, there are so many things which are unpredictable, and you don't know what is to be done, because what you see on a slant may not be true when you see patient under the microscope. So can I just share the screen to show a few of the basic cases?
Sure, sir.
Thank you. See, I want to show you this first case, which is a trauma. Just hold on, please. Now, if you see this patient, you can see a typical rosette cataract. You see subluxation, which is not continuous. So here you can see around 15 degree. Here you can see around 5 degree. Zonules are attached here, and the rest of the place they are attached. So this is the beginners, you can say, guide to put a lens where you need to put only plain, simple CTR. Am I right? Are you getting me?
Yes,
now,
sir.
when we planned for this patient, apart from trauma, he had astigmatism. Now, this case is done into the era where the toric lenses were not available. So let's start this. So this shows that area of zonular damage. Here, zonules are there. So in this patient, since there is astigmatism, we have done something what we call as a limber relaxing incision to control the astigmatism. That's why you can see these blood clots here. So this is done as both the sides limber relaxing incisions are done. So that along with the surgery, we control the astigmatism also and give a better result. So this is the rexis. All the movement should be there. Basic principle is to be away from the subluxation so that you don't put pressure onto the zonules, onto the, that side. So everything is going from zonular damage to away, including, you can say, hydrodissection. Now, this is a soft cataract, not a very hard cataract. But everything it should be remembered that this area of zonule should not increase. And for that, all the movements should go from zonular damage to away. This is the basic principle of this surgery. Now, since this is a soft cataract, we are trying to put the CTR first and then do the irrigation aspiration of the cortex. Now, if you see that we are putting a 3-piece lens and haptics are being placed in such a way that this covers the area of the zonular damage. This is how it will look. Okay, we go to the second case. Just hold on, please, if you don't mind. Why I'm saying that it is very unpredictable in case of trauma, that we don't know what's coming, when you are doing the surgery. This patient is a trauma patient. And as you can see, this is an inflammatory anterior synechia. Zonules are not here in this area. Zonules are here, but this area also missing, and this area is missing. So, and you can see a corneal scar here. Can you see the corneal scar here?
Yes,
this
sir.
is the corneal scar. So now we are again doing the same principle by which we are going, not trying to preserve the subluxated area in such a way that all movements are going to go into that area only when it is required. Then only this will not get increased more. Again, the hydrodissection, and you do the phaco the way you do. It's a bit of hard cataract because there's a trauma, there's inflammation, there are posterior synechia. If you remember that this posterior synechia are not separated at all. It got separated on its own. So that you can tackle small posterior synechia at the end of surgery if it is required. Otherwise, there is no need. And you do irrigation aspiration, again, preferably try to put the only simple CTR, because the subluxation is not very big, but it is at multiple places. And that's how it's going to look at the end. And, most of these patients do fairly good. And we again rotate the lens in such a way that this area on which you saw 2 or 3 subluxation area is covered. You remove viscoelastic from the front and the back part of the lens, and then we can just go ahead. Many times it happens that, as I said before in the trauma, some things you know only during the surgery. If you see this patient, there are a posterior synechia here, there's a fibrosis here, long-standing fibrosis here, and there is a dialysis here, and you can see a lens also been dislocated in this area. So just see what we are trying to do now. Now, since we want to go ahead with the surgery, that is a phaco surgery, we want to do with a hard cataract, with subluxation, we are trying to remove the synechia. But since there is a fibrosis in one direction, it's not working very well. So what we have to do that if it is not coming on one way, try from the other side. Once you try from the other side, it is broken. Now, if you see that this phaco, what I'm doing, that I'm doing on a left side. I'm not doing into the center. So then I'm going away from the area where there is a subluxation, which is there. So once you do the phaco and you put a 3-piece IOL there, again covering the area where the subluxation is there. And now at the end, we have to tackle this. There are many ways of tackling the dialysis, but in this, what we do, we pull the iris, take a suture from the center of the iris, and put it to the inner lip of the sclera inside. What suture which you saw now is the inner lip. So when you tie it, you are going to see this, at the end of the surgery, and that's how it looks. Pressure and other things which we check, and you can see that dialysis is corrected very well. Many times what happens in some trauma, you have a subluxation which is beyond your control. So any subluxation which is up to 90 degree, you can use a simple CTR. So 90 degree to, you can say, at least 110 degree. The time it crosses 120 degree and goes to almost 180 degree, we need to use something what is called as a Sion's ring. We'll come to that now. Now, if you see here, though it looks 180, actually it's more than 180 degree, some part we cannot see. Now, in this patient, we have to contemplate first that where should our axis should remain and how it is going to look at the end of the procedure or when you put the IOL. So this area, we have to contemplate that this area where we should not do the rhexis. So this is how you do the rhexis. Now it is looking eccentric to you. Now, this was the question which was asked. So you should take an incision 180 degree away from the incision where you fix it. Now, this was done into the area where the capsule hooks were not available. So we have used only iris hooks. Hydrodissection, and we do the phacoemulsification. Now you can see that blag is so flabby that it cannot be, you have to be really careful. And the hooks also, you have to keep it a little bit loose because that time capsule hooks were not available. The purpose to show you this case, though it is an old case, is to show that how do you tackle the cases when you don't have a ideal equipment in your hand. So now what we do, this is a 1.2 millimeter incision. We are taking away from the limbus. At 1.25 millimeter, I'm creating a groove. And I'm doing only 0.25 millimeter dissection to create a pocket. The reason I will tell you. Now we have released the hooks from the bag. And we are passing the needle through this groove which we have made. By using a 16 millimeter ring or 16 millimeter needle, and we are reloading this needle in diagonally opposite area of where there is maximum subluxation is there. So you are passing the needle which is going through that dissected area. Now, if you see that even to put the ring, I had to retract the bag, put it into the bag in such a way that it fixes the ring inside. You don't have to do here much. You just pull on to it and the ring will be pushed there, So Sion's ring will come here now. Now you tie these sutures. When you are tying the sutures are not going into the sclera. It's going into that small groove. So this is the hidden sutures. We prefer a 3-piece hydrophobic acrylic lens, because the optic haptic junction is good. We put the lens inside, and the haptics are positioned in such a way, in spite of having a Sionis ring, we are still trying to have that half of the ring into the area where the subluxation is not more. Now, at this stage, I'm taking the remaining cortex. I'm bringing it to the center and then sucking it, so I don't damage the bag anymore. Now you can remove the retractors. Now the knot which was there taken here, it will be buried inside here, the way it is shown here now. A very simple technique. Cauterize the conjunctiva. This is how it looks at the end of the surgery. First post-op day, pupil is small, you see a subconjunctival hemorrhage. And this is how you see, and after 1 month post-op, it is as if nothing has been done.
Excellent, sir.
Thank you. See, sorry, the idea here is to show, I'll just stop sharing the screen, sorry. The idea here is to show that each case, as far as the trauma is concerned, subluxation is concerned, you cannot plan everything before the surgery. There are many things we have to take in hand during the surgery, keep all the type of equipment which you need ready for that. And most of the decision, at least 30 to 40% of the decision you have to take on the table. That this is what should be done. Thank you.
Ravindra sir, can you enlighten us the timing when a CTR should be implanted if it is a small dialysis?
That's going to be a theoretical question for me because I don't use CTRs at all.
Okay.
So I've not used CTRs for a decade now. But for the exam going students, there are many ways of implanting CTRs. One is when it's very severe, right in the beginning, as soon as the rexis is done, you can do it. Or after the nucleus management, or after the cortical aspirations, depending upon how floppy is the capsular bag. So as I said, all these cases, the removal of cortex is extremely important. Once you put a CTR there, it becomes a little tricky. CTR goes and engages the cortex against capsular bag unless you rotate it, pull it tangentially, it may be a little more difficult to remove it. I would rather, if I put a CTR, would like to postpone it as far away as possible in the course of the surgery.
Any highlight about the IOL placement and haptics placement in such cases?
I think Dr. Jeevan has covered extremely well. As I don't use CTR, I don't use CTRs. It's mandatory for me to place it in such a way that the convexity of the haptic is abutting the maximum center of the maximum subluxated. One of the most important things that you have to see, we don't see zonules, we don't see the periphery of the capsular bag. We do so many things in the pupillary area, imagining that everything is good. So, but if we can visualize three-dimensionally how much damage we are doing to the zonules by various techniques, he stressed upon the fluidics. Fluidics has to be absolutely low. The lowest fluidics you can comfortably operate is the one that you should adopt in such complex situations. And let it take another 10 minutes extra or 15 minutes extra, but go slow on every step. Don't have 400, 500 pressure inside the eye, which pushes the entire capsular bag backwards, putting a stretch on the zonules. So these are tiny things. Cortical aspiration, as I said, is very important. I can show one video of extreme. You'll have to differentiate trauma from the degenerative conditions. You'll have to be a little more conservative in degenerative conditions, expecting that it will progress post-operatively. You'll have to plan for what's going to happen to those zonules, not today, but in the future, 5-10 years' time. I am a big fan of iris claw lenses, having implanted hundreds of scleral fixation lenses. I've totally switched over to iris claw lenses, and that's probably one of the finest way to minimize post-op trauma. The eyes look as though you're not touched at all on first post-op day. You don't have to band-aid these eyes. The surgical time is very, very quick. That you highlighted, surgical time has to be quick. We are not trespassing the hilodal phase. We know that vitreous base is very precious in an eye. We do everything, so many things, because it's all looks good because we don't look at it. But if there is a camera which is inside the eye looking at how much damage we do when we do these various procedures, so I have a strong case to put up in favor of iris flaw lenses.
Thank you, sir. Any risk of tryptophan blue, sir, passing to the vitreous cavity in such cases of subluxation?
There is a potential entry to vitreous through the hyaloidal system, or when there is a tear there, there's a right royal way for these things to go. Whenever you inject any of these things, ensure that you are either injecting them in the antechamber, or ensure that the force is not applied towards the sulcus, ciliary sulcus. But the space between the iris and the capsule, no force should be exercised in that direction, because then it can easily go between the iris and the anterior capsule, reach the triangular space of the posterior chamber, then percolate into the vitreous cavity. So the visibility comes down a lot. So you can't enjoy the red reflex. Of course, it doesn't cause any problem, but the control you have on the eye because of red reflex is totally lost if tryptophan blue goes inside the eye.
So, one last question, Pandit sir, if allowed.
Yeah, please.
Ladi sir and Rani sir both. Sir, you said you don't treat CTR, but there are cases of progressive zonular weakness like pseudo exfoliation, and when there is a severe pseudo exfoliation, later in time, patient might present with the IOL subluxation maybe over a period of 8 to 10 years. So, do you advise putting a prophylactic CTR in this case, or you plan a direct iris claw in such cases? Both.
As I said, we don't see what's happening to the zonules when we are doing all these steps. So putting a CTR itself is traumatic to the eye. If you look at the what you're doing there, if an IOL can dislocate, IOL capsular black CTR, everything can get dislocated. The dislocation happens at the zone of zonules, not at any other place. So the CTR is within the capsular bag. Still, whatever can happen to the zonules can happen even with the CTR, and it can get dislocated. We have seen any number of capsular bags which are in the vitreous cavity along with intact CTR and the capsular bag. Everything has to be removed. So I don't think it gives any additional. What it does is it centers the lens well if you put a CTR. And the second is it gives a plane. The tilt will be much lesser if you put a CTR in case of it. They are the minor advantages. But then the prevention of this dislocated capsular lens bag is not prevented by putting a CTR. Can I see this small video? It should
yes,
say
sir.
much.
Yes, sir, please. Yes.
Are you able to see this?
Yes, sir.
Yeah. This is a case of microspherophakia in a young person, maybe patient is around 20-25. Wherever my concepts are a little different. I always do it on the temporal side, wherever the dehiscence. Here the dehiscence is all around, and you can see the lens there. And my plan here was to do a scleral fixation lens. So I made two entries for fixating the enclaving the optics exactly 180 degrees away from each other. Then my plan was to remove this through a tunnel. How to do a rexis? I didn't want to make a large incision. How to do a rexis? So I made two punches, one opposite each other, because the entire zonules are weak. So it's not possible to do rexis unless I hold the capsular bag. How do I hold it? This is entry to inject the insert the lens later. So I am holding it like holding a bag. The bag handle technique is the one. Then with holding the with a short bent 27 gauge cannula, I could complete the rexis. You can see, otherwise the lens will be moving all around, further damaging the zonule, whatever zonules that are remaining there. Anyway, I was not planning to keep the posterior capsule. At the end, I wanted to remove it. But then during the surgery, I modified my approach. Then a soft nucleus, you can easily aspirate after doing the hydrodissection. delamination and delineation. So aspirate it out with a simple cannula, that's complete. So at the end of it, I'm left with a capsular bag. As I was about to pull out the capsular bag, I thought, why not a retain instead of removing it and taking the risk of hyaluronic phase getting exposed. So I'll go a little fast. So remove the entire thing. I could have put a CTR, I could have anchored the thing into the spherical cavity, but that's not my cup of cake. So at this time, I thought I'll leave this capsular bag behind, knowing that this capsular bag may become opaque. In front of it, I have placed the iris claw lens. The first time I did it a couple of years ago. So that's the iris claw lens which goes inside. So the vitreous is totally untouched. Hyaluronic phase is totally untouched. I've done about more than a dozen of them now over the last 3-4 years. I was expecting the capsule becoming opaque very quickly, but fortunately for some reason, all these capsules have remained clear. So now we can see so easily without doing anything major on the hyaluronic phase, I can enclave the lens behind the iris, and it looks beautiful. Being a young person, then I had to put a couple of stitches, 1 or 2 stitches. Otherwise, in an adult, it's not necessary to stitch. I can just send the patient with the eye open. And this is something which I thought I should share in a very advanced case of. Now it looks, because of pilocarpine, it looks ovalish, but then next day it's absolutely round. So 1 stitch there. The other eye was done a few days ago, and that's how it looked. There I put 3 stitches because there was an unstable panel. And you can see the pupil is reacting, the posterior capsule is intact, which has remained clear. Yeah, I thought I'll share this case where I retained the posterior capsule, retained the virginity of the vitreous. But please don't quote this in the exams. This is just for your information that the surgery can be done in many, many ways. I've even implanted in the past, maybe 20, 25 years ago, I've implanted a lot of Kelman lenses in this scenario. Even they have done extremely well. As long as you protect the endothelium, as long as you remove the cortical material, as long as your surgical skills are extremely good, as long as you don't end up in a lot of astigmatism, the results are fabulous in every case.
Sumit, anything you would like to sum up?
No, sir. I think you can share your cases now. PG cases and all. Thank you, sir, for that super video, both of you. Really.
Is it visible?
Started screen sharing. You cannot see the video as such.
No?
Yeah, we can see the video now. Yeah.
So let's see this video. Echo is going on. And suddenly iris has started prolapsing from the incision. Still, we are going with the phaco trenching, and iris is out, started coming out. So this is a typical case of a floppy iris. I would ask the panelist, what should be done in such cases? Should we stop phaco and fill AC with viscoelastics?
The first, can I talk?
Yes, sir. Yes.
Okay, thank you. The first part, stop phaco and fill antechamber viscoelastic, fair enough. Use of atropine will not help. Pain management in these cases is under a topical anesthesia. During this surgery, you can put a proparacaine, take a snip superior nasally, cut the conjunctiva and tenons and give a subtenon, which is a 1%, which is 1% lignocaine, which is preservative free, and you can repeat it as many times as you possible. Now, you are lucky to have only a small part of the iris coming out of the eye. Many times, if the flow rate, parameters, and height of the bottle is not kept low, we can have more and more iris coming out. Ideally, in this situation, I would take sutures to this wound, make another wound, and then go ahead with the iris retractors or any people responders which I showed you. That makes my surgery more predictable, causes less damage. It may take a little bit more time. And I would like to add about the anesthesia. You are not happy about topical and subtenon. During the surgery, what you can do, you can fill the anterior chamber with a viscoelastic, do a little bit of hydration to the wound, and you can give periorbital anesthesia without giving any pressure. Only thing we have to see to it that you are using good enough of a hyaluronidase that is going to spread the anesthesia better. I would do a first injection into the lower part, that is a lateral 1/3 junction to the medial 1/3 junction. I would like to give at least 3 cc there. Medial 1/3 and lateral 2/3 lower lid, I would like to give a 2 more cc. Wait for some time. At this time, actually, surgeon doesn't want to wait because he's into panic mode. But unless you bring eye back to a standstill, you cannot do a procedure comfortably. After these 2 injections, if you wait for 2.5 to 3 minutes, if this is not working, we can give 1 more superinasal 2 cc. Now, all this is going to take more than 3 to 5 minutes. But if you don't want to wait for this, I devised a modified caruncular block in which you take a 26 number needle, go to the caruncle. If you see a caruncle has only connective tissues and a fibrous tissues, and number of nerve endings are very less. So just put a puroparakane, put 26 number needle, and inject only 2 cc into the caruncle, which will go along to the medial wall of the orbit. Only thing here is that you have to wait minimum for 2.5 to 3 minutes. This is going to act like a retroliber, give you a good, you can say, a kinesia and anesthesia both, and then you can proceed with the surgery. My only request in this type of cases is that have a bit of a patience and have a bit of a wait till the time you get eye at a good standstill level, then you can do any surgical maneuvers you want. Thank you.
Thank you, sir. Dr. Ravindra, sir, can you like to highlight any points in such case?
Yeah. See, why does the iris get prolapsed? Because iris, and it's a vicious cycle. Once it gets prolapsed, it becomes more and more nasty to come out of the eye. It's because you are, as you said, you become panicky and inject more and more viscoelastic into the eye. And this viscoelastic, after filling the chamber, has to go behind the iris and push it back, push it out. So you should not deepen the antechamber too much in such cases. With too much loading of the antechamber should not be done at all. So very gently do it, and it is the fluid or the visco that goes under the iris which pushes it out. Okay, and you can even do a small buttonhole iridectomy there for the fluid to come out rather than pushing the iris outside. This has helped you. And instead of as I said, you can put a stitch, narrow it, and if it is too much, and take the probe, whatever probe you are using it, on the prolapsed iris, and the probe itself will hold the proximal iris backwards so that it doesn't prolapse. There is no room for it to come out. The next is atropine doesn't help at that point of time. Tamsulosin will not help, but preoperative use of flurbiprofen or any non-steroidal will certainly help. Pain management, actually, iris prolapse does not cause pain. It is the pull on the ciliary body by the iris root that causes pain. And if you inject anything into the orbit, the orbital pressure goes up and it's going to push the eye up, and there'll be more and more vitreous pressure and more iris prolapse. I would desist from injecting anything to the orbit. Instead of that, what is the cause for the pain? The ciliary body. Take 0.1, 0.2 ml of lignocaine, 1% that's available, and push it behind the pupil. Don't push it towards the zonules, but push it so that it percolates into the ciliary body area, root of the iris root, and then that gives complete numbness of the eye. You can continue with topical with that. So these are my tips. And the medial canthal block is a great one. The landmark, surface landmark is medial to the medial canthus. Medial to medial canthus. Medial caruncle is there. Between the medial canthus and the caruncle, you have to go straight. You can go deeper than half inch of 26. You can use a 23 and go up to the back of the thing. That gives a very good block in case the patient continues to have pain. But my philosophy is do not pressurize the globe, do not pressurize the orbit by giving any additional injections.
If the patient is on stem solution, how many days before should we stop his stem solution, and any role of that?
It doesn't help you, sir. Even if patient was on stem solution a couple of years ago and has stopped it because he underwent a surgery, still you can expect to see iris floppy syndrome, floppy iris syndrome. It doesn't help. I don't stop tamsulosin at all during before surgery.
We'll go to the next case scenario.
What about others? Do you stop? What is the general consensus?
It doesn't happen. It doesn't help in any way. Even if you're taken tamsulosin for 2 days also, it's going to cause same reaction because it goes into the stroma of the iris and acts there. So you have to be ready with the all armamentarium to tackle the case, whether the patient is taken for 2 days, 2 months, 2 years, and stop or not stop, doesn't matter. Every time, thank you, sir. Every time it may not happen that each case is going to give you trouble. Again, that decision has to be taken on the table. Many times it happens that you just come out without using any extra instruments, and you can do the case well. Only thing that keep the parameters low, as sir said, and you can come out well. There is no issue. Only if it is required, then only you can use retractors and other instruments. Thank you.
We'll quickly go to the next case. It's a case of has a dense corneal opacity and cataract. So phaco was started, going on well. Yes, is being. Here, I would like to ask the panelists, what should you do in such cases with a corneal opacity? Should we proceed with iris hooks, or should we go with a plain SICS in such cases, and role of light pipes in such cases? Ravindra sir, please.
I'm a fan of SICS. I would straight away go for SICS and save all my tension. My adrenaline remains, under control. So I'll not be worried. And you already answered. Light pipe is one of the great way. Light pipe is always available, and switch off the microscope. Put the light pipe. It doesn't have to go inside the eye. So you can just put it near the limbus so that you have a lateral illumination. Only thing is you don't have a coaxial illumination in such patients. Whenever you want coaxial, switch onto the microscope. Once you remove the cortex, the mature cataract material, then you can switch on to the coaxial and continue with the surgery, cortical aspiration, IOL implantation. But light pipe is a great asset in such situations. I know some surgeons who have taken light pipe into the vitreous cavity and they to illuminate from behind. That is, I have not done it before. But light pipe kept near the limbus itself is a very good source of visibility in these cases. And of course, trypan blue and all that will certainly help.
Dr. Ladi sir?
Dr. Pankaj, what we saw on a screen now may not be a picture which actually surgeon is seeing under the microscope. So though you see opacity in a unidirectional way onto the screen now, you can still have a really good glow, especially in the case which you have shown, unless it's a total corneal opacity.
Yeah.
Now, what I saw here is you can say, not a nebula, not a leucoma. It's like a macular type of opacity. So you still get some good illumination through a coaxial microscopic thing, and you can do it. Now, okay, I have a pipe, I will use it. But there are many settings the pipe may not be available. Like, can you just stop it here? Can you just hold it here? Okay. Now, if you see here, this is the area which is not been seen. Now, if you see, I would prefer to use an iris hook here to make the area clear. Now, from here, I'm not seeing at present here anything now. The time you put iris hooks in this direction, this area which is not dense will start getting illuminated by the retroillumination. And you can still continue the procedure and do it. Now, I don't have a pipe. If I have a pipe, well and good. I would prefer to put a pipe here to complete one part, and then I would like to put here. Can you just, or you can go in this direction? But I don't have a pipe, So what I do, I don't have a pipe means I meant to say that I have a pipe, but there are many people who may not have a pipe there, light pipe. You can use indirect in your OT. That indirect light goes in this direction. Only thing what you have to do is that you have to put off all of the lights, otherwise you will not see it well. So microscope with the indirect light going in one direction, either this or this direction. And this is going to be helpful more for the capsulorhexis. As soon as the capsulorhexis is over, your major part is over. Then you switch back onto a light or coaxial illumination. And if you've seen on any microscope, there's a knob onto the right side or on the left side where you can take an oblique illumination. Take an oblique illumination and start doing your phaco, and you'll be able to do it. Only issue comes where that opacity is from here to here, then you have a trouble, especially if it is a leukomatous opacity. Then the pipe is mandatory. Then you cannot proceed with the procedure. Otherwise, in this case, I'll be fairly happy just using iris hooks and indirect light. Yes, that's the way I wanted, and just use indirect light from this direction for initial part of the procedure. Thank you.
Thank you, sir.
Even if you don't have the light pipe, even a powerful LED light which gives a very focused light, ask somebody to shine it from the temporal side and continue with the surgery. So the light has to be focused onto the limbus or little onto the corneal side. Torch light is also good enough.
Agree, sir. Absolutely agree.
The one more thing that I would like to say is assess the corneal opacity before surgery. We have seen wonderfully sometimes, you peel off the anterior stroma epithelium. Sometimes we remove the epithelium. If the opacity is limited to anterior stroma, suddenly you start having very good illumination. So you soak alcohol and keep it there and remove the epithelium, just like we do it for LASIK patients. So if the opacity is related more to the Bowman's area, you can even scrape it and, then after scraping, keep putting viscoelastic, you'll have wonderful vision. So that's another assessment of the location of corneal opacity is something which is of great use. You can do a OCT with the cornea also. Yeah.
In this patient, I would like to spend a little bit more time on a slit lamp, OPD. What will I do in this patient? I close my entire room completely, start the slit lamp, make the position, and put off all the lights and keep only slit lamp light on. And I see coaxial and I saw oblique both the times. So I get some clues that what I'm able to see under the microscope. So I see through the opacities. Am I getting some light in between the opacities? Do I see something as a red glow coming towards me through the opacities? If I'm, say, 70 to 80% fairly happy, then I know that under the microscope, I can do this job. But on a slit lamp, when I know that, this light is not coming back at all, that's the time, then I resort to the other things which sir has said.
It's really great having so much of inputs from all of you, and especially Ravindra sir and Ladi sir. Sumit, would you like to sum up?
Yes, that was superb discussion. Thank you. For the closing remarks and comment on subluxated cataract, we have Dr. Atul sir. Sir has interest and he has experience with using ASI anchor for subluxated bag and the lens complex. So I would ask Atul sir to kindly comment on the same and also the closing remarks from him. Atul sir.
Thank you so much, Sumit. Actually, I did my first SC anchor case in 2017. It was similarly a traumatic subluxated lens, almost 6 hours of subluxation. The greatest advantage which I found with the SC anchor is that here you can fix the back before you remove the cataract. Whenever you use the Sionis ring or whenever you use a CTR, CTS segment to fix such large sort of subluxation, you have to first deal with the cataract and then you fix the back. So it's not easy to do a cataract in a case where the back is already compromised or in a subluxated position. And secondly, if the part of the subluxation is more, we can use two SC anchors also. And once the bag is fixed, the removal of cataract is just like we do on day-to-day basis for cataract. So I feel this is one of the good way. Using a Sionis ring is not that easy. To pass and ring through a subluxated bag many times, you can shear out other zonules also. So I had done up till now 4 cases. And the first case when I did, I had a con call with Dr. Ehud Assi. He is the founder of the SK Anchor. And after that, I had done one Marfan syndrome case also where I used two SK anchors to fix that large subluxation. And up till now, the whenever the with the follow up, the patients are happy. I can see the round circular pupil and almost a very good post of vision also. So this is just 2 cents from me. I know I'm in a stalwart of so many good people. To just conclude in the secretary's post for a vote of thanks, you all PGs, I can say, and all our MOS members are so much lucky enough to listen to Dr. MS Ravindra sir. I'm very much fond of him. In all WhatsApp group, whenever I saw any post from the sir, I used to read it because I know it is going to give you 2 cents, something which gives an extra edge. He had a very good, I think we should have a session on autoclaving or an sterilization aspect also. Sir had cleared so many concepts of me, and we are all lucky. We have Dr. Jeevan Ladi sir, our own faculty, but he is an international caliber person, and we are lucky to have such a person in our fraternity. Recently, we all know his formula, and that is for this. You can understand that. It is a cost saving also. So you can have an result as compared to the highest, the expensive instruments with his formula and with his immersion methods, you can have the same result. Thank you, Akhilesh, and for the nice case presentation. We have Dr. Pankaj Shah. He has moderated the session very nicely. And Dr. Avantika, madam, thank you very much for being here. Thank you, Team MOS. And as usual, Sumit is the person who is the main person, the man behind the whole PG shows. He takes a lot of pains, and it really, I can understand from the secretary point of view how much pains he has to take to arrange everything in place for all of us. So again, Sumit, looking forward for the next Thursday with another good session. And thank you very much. Thank you to all.
Thank you.
Thanks a lot for the inviting us, and we are really pleased. And it's my privilege to be there with MS sir, and been very big fan of MS Endra sir, and you all the guys who are so prolific in your own profession. So thanks a lot, and I'm really grateful.
Thank you, sir.
Thank you, sir, and congratulations to Jeevan Ladi sir for such a wonderful concept he has come out with.
Thank you.
Thank you very much. Ladi's method of biometry. Thank you. Thank you, Ravindra sir, and thank you everybody who has contributed immensely for the success of this PG activity. Thank you.
I think I forgot the name of Divisha to thank you. Thank you to her also. She also presented the case nicely. And thank you my team MOS, Aditi, Vardhaman, and घर के लोग हैं, उनको thank you नहीं बोलना चाहिए, but still we complete it. Thank you.
Yeah, thanks to everyone for giving me the opportunity to learn from you.
Thank you, everybody.
Thank you, everyone.
Good night.
Thank you and good night.
Good night.
Good night.
Good night. Good night.
Good night.